Hello, everyone, and welcome. So, I'm sure you've all heard of water pills, right? They're everywhere, some of the most common medicines prescribed. But have you ever really stopped to think about how they actually work? Well, today we're going to do exactly that. We're going to take a journey deep inside the kidney to uncover the fascinating story of these drugs we call diuretics.
So here's our plan for today. First, we'll start with the basics, what these water pills are all about. Then, we're going to take a little tour inside the kidney's amazing filtering system. After that, we'll focus on the main hero of our story, thiazides, and see exactly how they do their job. Then, of course, we have to talk about the good and the bad, their uses and their risks. We'll also look at a very clever solution to one of their biggest problems. And finally, we'll wrap it all up with the delicate balancing act that is pharmacology. Let's get started.
Okay, first section. Everyone calls them water pills, but that name is it's a bit too simple. It doesn't tell us the whole story. To really understand them, we have to ask a much better question. What are they actually doing inside our body?
So I'm sure you have, it's a very common name, but in our field, the proper term is diuretics. And you have to understand, they don't just magically get rid of water. No. Their real function is much more clever, much more strategic than that.
So, what's the textbook definition? A diuretic is any substance that promotes something called diuresis, and diuresis is just the fancy medical term for making more urine. It sounds simple on the surface, doesn't it? But trust me, the how is where all the really interesting science happens.
All right, now let's go to the location. Where is all this action taking place? For this, we have to dive deep inside the kidney, into this tiny microscopic powerhouse called the nephron. Remember this, the nephron is the functional unit of the kidney, and it's the main stage for our entire story today.
And you know what? We can be even more precise. The main stage for the diuretics we're talking about today, the thiazides, is one specific part of the nephron called the distal tubule. Please keep this location in your mind. It's absolutely crucial for understanding everything that's about to happen next.
Okay, so it's time to meet the star of our show, the thiazide diuretic. We are about to see its mechanism of action. And it's really quite elegant, beautifully simple, but incredibly powerful. And it all comes down to blocking one single, very specific gateway.
Right, have a look at this diagram. It shows us everything. Let's walk through it together. On the left side, you see the luminal membrane. That's the side which is facing the urine. Now, can you see that channel, the one labeled NaCl symporter? Its job is very simple. It pulls sodium and chloride, salt, out of the urine and back into the body's cells. But now, here comes our thiazide drug. It fits perfectly into that channel and just blocks it. It's like putting a lock on a gate. The gate is now closed.
So let's just quickly summarize that effect. Step 1, thiazide comes and blocks that salt channel. Simple. Step 2, because the channel is blocked, the salt, the sodium and chloride, gets trapped inside the tubule. It can't get out. Now step 3, here is the golden rule of physiology. You must remember this. Water always follows salt. So, if the salt is trapped, the water stays trapped with it inside the tubule. And the final result? More water in the tubule means more urine output. Diuresis. It's a beautiful, simple chain reaction.
But you see, like any powerful medicine, these drugs are a double-edged sword. They have incredible, life-saving uses, for sure, but they also come with potential problems, complications that we always need to be aware of. So now, let's look at both sides of this coin.
So what do we use them for? Well, mainly for edema. That's the swelling you see from excess fluid, especially common in heart failure. They are also a first-line go-to drug for treating hypertension or high blood pressure. But they have some other very interesting uses too. For example, in a condition called diabetes insipidus, they do something completely opposite. They actually reduce the urine volume. It's a paradoxical effect, quite fascinating. And they can also help prevent certain types of kidney stones by making sure less calcium is lost in the urine. So you see, they are incredibly versatile drugs.
Okay, now for the risks. And please, listen carefully. If you remember only one complication from this class, it has to be this one, hypokalemia. This is considered the single most significant problem. So what is it? Hypo means low, and kalemia refers to potassium. So low potassium in the blood. This is the big one we always worry about.
And besides low potassium, which can cause everything from simple muscle cramps to very serious heart rhythm problems, there are other risks too.
If you overuse them, you can get dehydration, of course. They can also increase uric acid levels, which is a problem for people with gout, and they can raise blood sugar levels. And with long-term use, the body can lose too much magnesium. This is why it is so important to monitor patients on these drugs very, very carefully.
So that problem of losing potassium, it was a major challenge for doctors and scientists. So what did they do? Well, the pharmacologists came up with a very clever solution. They created a whole new class of diuretics, one designed with a completely different strategy in mind, specifically to save the potassium.
This diagram shows us exactly how they work. Now, notice we are in a different part of the nephron. We've moved further down to the late distal tubule and the collecting duct. See the two drugs shown here, spironolactone and amiloride? As you can see, they target completely different pathways, but they achieve the same result. They cause a mild diuretic effect, but, and this is the crucial part, they prevent the loss of potassium. This is why we call them, well, potassium-sparing diuretics. Makes sense, right?
And this just shows you the two brilliant strategies they came up with. On one side, you have spironolactone. What does it do? It works by blocking a hormone called aldosterone. By blocking this hormone, it stops the body from secreting potassium into the urine. Clever. Then on the other side, you have amiloride. It takes a much more direct route. It just goes and blocks the sodium channel itself. This changes the electrical gradient, so there's less incentive for potassium to leave the cell. So you see, two different keys for two different locks, but both open the same door. Very, very clever pharmacology.
So after all of this, what is the big takeaway message? When we compare these different drugs, we see that using them is not so simple. It all comes down to a very, very delicate balancing act. And here is the most crucial point I want you to take home today. Using diuretics is a constant balancing act. The whole goal is to get rid of as much excess fluid and salt as we can, while at the same time losing as little of the essential electrolytes, especially potassium and magnesium, as possible. Mastering this balance, that is the true art of using these drugs safely and effectively in our patients.
And that brings us to the end. It's really amazing, isn't it? We've just looked at one tiny chemical process happening in one tiny part of the kidney. It just makes you wonder, right? What other incredible invisible chemical battles are being fought and balanced inside our bodies at this very second? Something to think about. Thank you all for listening. I hope you found this useful.